Good evening, everybody. This is the North Andover Board of Health meeting for Thursday, May 24th, 2018. I call the meeting to order. To start, I'd like to begin with the Pledge of Allegiance. I pledge
allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. We're going to take it in order tonight. So, has the meeting minutes?
They've been critiqued and they're fine.
Do you have the, where's the folder for the meeting minutes?
Folder?
There we go.
Right
Okay,
here.
has everyone had a chance? Okay, do I hear a motion for the meeting minutes? To approve the meeting minutes for April 26, 2018? Second? Do we have a second? Mm-hmm. All those in favor of approval, say aye.
Aye.
Aye. It's unanimous. Okay. This is a very exciting meeting tonight. We're going to go down to communications, announcements, and discussion for our next area. Very exciting meeting. We have two guest speakers. Our first guest speaker is Dr. Frank McMillan, Jr., and Dr. McMillan is also our board member. He's to my right. Dr. McMillan is going to do the first presentation on the Surgeon General's report on addiction, local public health implications. Very, very, very exciting, and I'm going to learn a lot, and I hope everyone else does too out there. And the second discussion we're going to have, and our presenter is Ron Beauregard, and on educating adults on the proliferation of vaping, which is, I think, from what I hear, one of the biggest problems in school nowadays is the kids vaping at all the ages, pretty much. So, very, very exciting meeting. I hope everyone gets a lot out of it and learns a lot. Why don't we start with Dr. Frank McMillan?
Okay, thank you.
Thank you.
Well, thank you for listening to me. Let me just be upfront about what we're trying to accomplish. I had gone to this lecture given at the 2017 Mass Medical Society Annual Education event, and that's given at the annual meeting in Boston. And this was a very interesting lecture because it really changed the way I think about addiction. And I thought that I would share this, mostly because those of us in public health and on the board may not necessarily be expert in every issue that we discuss policy on. And so the purpose of this is really just to kind of bring us up to speed about what the state of the art is, and where better to start than the Surgeon General's report. So the slides that I have are not mine, but they're obtained from Dr. Thomas McClellan, who is one of the editors of the Surgeon General's report, which was published in 2016, Dr. Vivek Murthy, who was appointed by President Obama. Dr. McClellan is a PhD psychologist. He has he's a founder and the chairman of the board of directors of the Treatment Research Institute in Philadelphia, Pennsylvania. So I'm going to go ahead and just open that device up if I can. And just bear with me for a second until I go to the slideshow. Okay, so let's see, where's our device here? Okay. Does this have a pointer on it too? I got it, okay. Okay, so I want to just start with some key terms. We'll start with use, which is the use of any substance driven by market forces. Misuse is use of a substance that can cause harm to self or others, often driven by consequences. And then addiction, which is compulsive use, and that's driven by progressive brain changes. And as you'll see, what we're really talking about is an acquired organic brain disease. This is on serious, on substance use in U.S. adults. We go all the way from the bottom of the pyramid, from little or no use, to serious use at the top. And as you can see, addiction is about 21 million people in the United States. which only about 4 million are in treatment. Misuse, though, is the major cause of harm, and misuse does lead to addiction. So why should we care? Well, it's related to about 28% of college rapes and interpersonal violence, 44% of injuries among those aged 12 to 25, 63% of disabilities in that age cohort, and 74% of all deaths. And if you look at minority populations, the numbers are even higher. So it's not worth it. Annual cost is about $440 billion, and that exceeds the cost of both the Afghan and Iraq wars. So what can we do? This was where I was not too long ago. These are intractable problems. We're just going to limp and work through them. But it turns out that that doesn't seem to be where we really are. So if you look at any substance use from 2002 to 2014, here we go. You get about 22%, and that's fairly steady. Binge drinking seems to be increasing over time. But the premise of the Surgeon General's report is that we have misunderstood addiction, we have institutionalized inappropriate solutions, but we now know what we need to do to get it right. And the best example of that is smoking. Where's Ron Beauregard? Here we go. If you look at past month cigarette smoking from 1965, which was the year I was born, to 2015, there's an amazing drop from 44% of adults to 16% of adults. And that's a public health victory, and the country's healthier because of that. Reducing substance use and misuse and substance use disorders really needs a continuing care model. We can start at the bottom of the pyramid with families and communities, and that's why we're here tonight, to get educated on this. But in the substance misuse category, basically screening, intervention, disease management, and monitoring, similar to how we screen for diabetes. And then for people with serious misuse and addiction disorder, then we have the specialty treatment programs, but a continuing care. This is not something that's going to be solved 3 days in an emergency room. So we want to target the easiest low-hanging fruit first, and that's prevention. And the prevention at the bottom of the pyramid, this is targeting people with little or no use of substances. And this is the vast majority. And we also, this was on the previous slide, the misuse population is about 40 million, and then the serious addiction is smaller than that. But if you attack the bottom of the pyramid, you get less as you go higher. So we can reduce risk factors, and we can enhance protective factors. This was something that was very interesting to me, that the critical at-risk period for addiction is actually adolescence. And adolescence should really be understood to mean ages 12 to 25. So this is in middle schools. So we need to start young. And it also means that we can't forget people once they hit their 21st birthday. They're still at risk for developing substance use disorders. No single factor is determinative. The same factors predict many harms. So bullying, dropouts, pregnancy, drug use, suicide. These have been looked at. There are real programs, real tested programs that can modify these risk factors. So it's not hopeless. These are some examples of effective prevention policies: reducing the availability of alcohol by licensing, reduce underage drinking and driving while intoxicated, reducing the availability of prescription drugs. These have all been shown to be effective. Take the price of alcohol. When you tax something like alcohol or tobacco, you reduce the rates, and there's lots of data to support this. If this is done in states that have had state liquor monopolies, but when they privatized, the sales increased dramatically. And there are lots of case examples in the literature from this. This slide I thought was very interesting. This is U.S. traffic fatalities. And there's a big drop right around 1990. Anybody know what happened right around that point? age 18 to 21, Mothers Against Drunk Driving, and look at the risk reduction. Let's talk a little bit about treatment. Your treatment target population is going to be at the top. You have the misuse at 40 million and the addiction at 21 million. Historical definitions of addiction, unfortunately, have kept us back. Addiction in the past has meant a character disorder, that the addicts would need tough love. They would need to follow rules, get with the program. Also, that addiction equals physical dependence. That's not true. We've had that discussion with cannabis, that only hard drugs produce addiction. Any substance that lights the brain up can produce addiction. That addiction is the result of bad choices and deviant lifestyles. That's also not true. Addiction has not been part of healthcare. Most medical and nursing schools don't teach it, and there's virtually no primary care involvement. Addiction has not been reimbursed, and it's been eliminated or carved out of coverage. So not only is there no access to care and treatment, but it's not covered by your insurance, and that makes it hard for people to access it. And then finally, the stigma, where families feel shamed, and so they're less likely to reach out. But there is new science, and the new science is in diagnosis, brain imaging, and also in genetics. The diagnostic criteria, you can look these up in something called the Diagnostic and Statistical Manual, and there's a whole list of criteria about substance use disorders. But what I really liked about this is a good general definition is diminished control of use. If you start losing the ability to control your use of a substance, you have a substance use disorder. So what could cause diminished control? Well, incremental substance-induced changes in gene expression, stress response, brain circuits controlling motivation, inhibition, reward sensitivity, and these changes don't stop when you stop using. They occur long after drug cessation, which we'll get into about what works and what doesn't work. So this is a PET scan of a patient with heart disease on the right. So you can see on the right, that's obviously different from the one on the left, and you don't have to have a medical degree to say, hey, that healthy heart looks different from the diseased heart, and it's metabolizing differently. So now look at the brain changes that you see in addiction. So the top three are basically normal brain function. And then the second one is there is reduced brain activity even after 10 days of abstinence. And let's go over 3 months. They're still not the same. So there are chronic changes in the way that the brain handles itself that occur as a result of substance misuse and abuse. This is a little something about the heritability. It turns out that there is a genetic susceptibility to this, and things that we would normally look at, non-addiction related, but the concordance in twins of asthma, eye color, diabetes, hypertension. These are really not that different. Addiction to alcohol, opioids, cocaine, and even cannabis. So it turns out that addiction can result from all substance misuse. Anyone can become addicted, but 50% of the risk is genetic, and adolescence is the main risk period. If you can keep people from misusing substance to beyond adolescence, very few people actually will misuse or become addicted at that point. The defining feature is loss of control, and that progressive misuse may impair the specific brain circuits related to reward, to stress and anxiety, and to executive function. And the brain changes endure after the drug use stops, which means that these people need ongoing care and monitoring. So addiction is different from misuse because of the enduring brain changes and enduring vulnerability, especially to emotional and situational cues that signal craving, and that these enduring changes are best managed as a chronic illness, and they require continuing care and regular monitoring. So the treatment goals are the same as other chronic illnesses: reduce symptoms to non-problem levels, improve health and functioning, and teach and train self-management. But the treatment methods are not the same. You need a personalized care program. You should use evidence-based interventions, including behavioral, medication, social supports, and you need clinical monitoring in order to guide your modifications to that program. So is there a model of appropriate care? Yes, the treatment of addicted physicians. This is actually true of airline pilots as well. It turns out that a lot of the professions that require people to perform at a high level don't throw away their addicted people. They have these programs to get them back into it. And every state has an addiction program that not only basically pulls people out of practice, but monitors them, and then once they get into practice, will monitor them for years afterwards to make sure that they don't relapse. So phase one, this is called evaluation and contracting. It's basically, it's a 3 to 5 year contract. Monitoring reports go to the board for 4 years. Phase two, this is probably not something that people need to get into, but I think that the point is that this is going on for years, including urine drug screenings, work site visits. These people are not left out to their own devices because we know it's a chronic illness, but we also know that if you do this, you get success. So through 5 years, no positive urine over 5 years, we get almost 80%. I think I didn't know that. That was news to me. And then if you get a positive slip up, still, most of those people will stay with the program. And there's reasons for that because of motivation and wanting to get back to your profession and things like that. But I think that there's a model here that you're not going to get people through their substance use addiction disorder by putting them into a residential treatment for 30 days. They need ongoing monitoring. So the conclusions really is that substance misuse is a public health problem. It's hurting and it's killing our young. Prevention policies and programs can reduce risk and enhance protective factors if delivered throughout that at-risk period. We're talking about, again, 12 to 25, adolescents. That misuse and substance use disorders are prevalent in all healthcare settings and they're ignored, and that these disorders reduce the quality and effectiveness and the safety of all healthcare delivery, and that substance use disorders education should be required in medical and nursing and pharmacy schools. Addiction is an acquired brain disease. Continuing misuse damages brain circuits and it leads to a loss of control. Family history is important, and those with family histories of substance use disorders and mental health disorders are most vulnerable. That critical at-risk period, and then these can be treated. This is not a lost cause. So again, this is just a repeat of previous for, at the low end, preventing them with families and communities, and that's what we're here for tonight. Mainstream health care for people who start developing misuse disorders, and then specialty treatment for those who become actually addicted. But remember, it's the low-hanging fruits at the bottom of the pyramid. And so I'm going to conclude my remarks, and that was pretty much my goal, to do this in 20 minutes. So thank you.
That was great. Thanks, Frank. Really appreciate it. Now, do you have time for questions?
I do.
Oh, good.
Do you want me to go to the podium?
No, it doesn't matter.
I'll go to the podium.
You want to do it? Okay. I wrote down a couple. Now, some I know, some I ask, so I want the public to hear too. So, pain medicines. Somebody goes in, has a bout with, unfortunately, with heart disease, needs cardiac surgery, has a bout with cancer, whatever it might be, and they're going to be on pain meds because it hurts. Terrible. So when you mentioned, and I learned some about the brain disorder syndrome that you were talking about, when does it actually begin? When you overuse and continually overuse to the point of that you're just out of it, or is it once you start needing pain med for however many weeks or months based on your illness, that you're going to automatically have some type of change on a PET scan, brain change on the PET scan?
Well, we're all different. None of us are going to react to this the same. But let's say you've had some kind of a surgery, and we all know surgery is painful. I think most of the people in this room have been victims of surgery or orthopedic injuries or things like that that are painful conditions. So we know that the time closest to the injury is when most of the pain occurs. and there is a legitimate need for strong pain medication to control that. The issue is that what the feeling is that you have a supply of pain medication that probably exceeds the need. And although you still have some pain, it's not horrible pain. And you could probably get by with something that is not as strong as an opioid, for example. But the medication makes you feel good, it helps you sleep, it blunts your anxiety. You've just moved into misuse. That doesn't make you addicted, but now you've put yourself at risk. Now you're misusing it. You're using it for a purpose other than for what it was intended to. You may get away with it, but if you do that for a long period of time, then you're going to put yourself at risk to develop these abnormal reward circuits. All substances work by what's called the lock and key hypothesis. So the drug is the key that goes into the lock, which is in the cell membrane, which changes the potential across the membrane and produces the clinical effect. So if you're always kind of taking the key and putting it into your reward center, well, guess what? Your reward center might change as a result of being continuously stimulated. You might actually need more stimulation to feel normal. Now, all of these substances actually mimic endogenous gates. So these are things that are already inside you that your body makes its own chemicals for. Endorphins is a great example. People who get a runner's high go out and they run and they feel great. And what happens when they don't run? They might get a little cranky because their endorphins are used to they're used to that stimulation, and it's kind of a self-reinforcing in a good way. The same thing with cannabinoids. Your body has an endocannabinoid system that controls your mood, your sleep, your satiety after eating. It controls a lot of things. It controls your gastrointestinal motility and your mood. And when you start stimulating that, what happens is over time the receptors change in their sensitivity to the stimulation, and it induces chronic brain changes that can set you up for problems, especially if you're genetically susceptible to that.
So over longer periods of time, these brain changes are more likely to occur than not.
Well, they'll occur with misuse.
Yeah.
And with duration of misuse. And again, not everybody who misuses is going to become addicted, but you do put yourself at risk. I think on the slide it showed about 40 million people misusing substances, and that's all substances. That's tobacco, alcohol, cannabinoids, opioids, et cetera. But and the Surgeon General's report was on addiction in general. It wasn't about specific substances. But the largest problem that we have with addiction in the United States is alcohol. Clearly, it's pervasive and it's misused by a lot of people. Not everybody gets into trouble, but 1 in 5 of us will have an alcohol problem if we use it regularly.
You know, just to,
Larry, on the
Yeah.
pain control, acute pain control after surgery, there's sort of a physical nature to it also, but there's also kind of what I think of as a psychosocial and a social network support of it also. And as a surgeon, today I write for probably a third of the amount of pain medicine I used to write 4 years ago for doing the same surgery. I don't think I do it any better. Maybe I do, but probably not. But it used to kind of travel over into that sort of that kind of crossing the gray zone of the patient taking it because they're having legitimate pain to taking it because, like you said, sort of just feeling good about it. Now I know that, and there's a lot of support from parents come in because I operate on a lot of teenagers where we can tell them, you take this medicine for a couple days, and then after the 2 or 3 days, then you can use non-narcotics and you can combine them and get a synergistic effect and not, sort of have the non-narcotic pain relief, but not the exposure and the continued duration and risk to that. So, but he's also right, everybody's different. You can't say there's one time frame at which this person any given person is going to be susceptible because of multiple factors involved, including genetic and past history and many other things.
no, thank you. I used to, when I was practicing in pharmacy, I used to advise patients because even then, they prescribe medicines for hyperactivity, depression, anxiety, and everything else. And you can add this to the addictive talk we're having today, because I would advise patients, if you're coming off a particular med, whether it's for depression or whatever else it is, you don't just abruptly stop. And a lot of doctors, you're right about that, in the training, they didn't know that, but we did get that in pharmacy school, even 40 years ago, as far as weaning people off and proper therapy for a lot of the psychological meds out there. And you do it slowly, and you do it under doctor's care. You don't just stop your, I'm not going to name any meds, but you don't just stop this med or stop that med and I can come off it and I feel great, so why continue? You never do that. You do it over a pre-planned time frame with the doctor, and that's the best way to have you control that whatever feelings that you're having, and not have that fear that if you don't continue taking your tablet, you'll never get better. So, and that was known a long time ago when I was back in pharmacy school, as far as psychological meds.
And speaking of being weaned off, as most, if not all of you know, I've had open heart surgery twice. I've had cancer, and the drug that I was given was opiates. They work. They work really good. And after a while, I said, I could become addicted, and I weaned myself off. And I'm glad that I did. I didn't want to, because they work well, but I was really concerned about addiction. And then again, I'm going back 10, 12 years. And the knowledge then was not nearly what it is today, but I'm glad that I took myself off.
They work very well in the short term. The problem
Yeah.
is over time, they tend to lose their effect. And if you talk to people who have been on, let's just call opioids for an example. I saw somebody in the office the other day, who had had a hysterectomy 2 years ago, and she was still on opioids. And I'm like, what is that all about? And it's like, are you still having pain? And she's like, yes. I said, then they're not working. They're not working. So you need to get off of them, because you have two problems now. You're on this. You're dependent on this substance, and it's not giving you the pain relief that you're looking for. And I think that's one of the things that have come up as far as in medical education is that we're much more focusing that if you are somebody who has a condition that does require pain medication, you need periodic assessment to find out if that medication is doing what it's supposed to do. And if it's not, well, then you need to make a decision to stop it and do something different. And there's lots of something different. But I think Dr. Trowbridge's point was that there's a certain amount of pain that occurs in the immediate postoperative period for postoperative pain that does require strong medication, but that really lasts a very short period of time. In my experience, 1 to 3 days, that's about it. And then you'll still have pain. People have pain for weeks or months afterwards, but it's not that kind of pain. It's something that can be managed, and it doesn't require medication that's that powerful. When you're talking about a cancer diagnosis, this is a different discussion. But we're talking about non-cancer pain, because these people are going to live a long time, and you need to think about how they're going to respond.
I just have one comment.
Yeah, please.
Go to the mic.
Sure. Are they on?
Yeah, you just have a seat, make yourself comfortable.
My name's Libby Strauss, and as some of you know, I am taking over as the president of the Merrimack Valley Prevention and Substance Abuse Project. So I've had the opportunity over the last few years to actually talk to a lot of people in recovery, talk to people that, are active users. I myself lost my daughter 3.5 years ago to a heroin overdose. And what we're talking about here, I think, is the effect on our young people. I mean, it's adolescence. That's when we need to get them. And unfortunately, and this was true for both my kids, their first taste was having their wisdom teeth out at 16. And I remember my son, because I came into the room as he was waking up, because I put him under, and his comment was, wow, this feels amazing. And that's before he even got the Percocet. And I mean, to have our kids, teenagers, exposed to this stuff unnecessarily. And my daughter, who later passed away when she was 21, she really liked the Percocet, only she didn't exactly tell me that, you know. I mean, and I was not clued in. I personally never really liked that stuff. I don't like being out of control. I'm a fan of ibuprofen or Tylenol. So these are just things that are going on, and you know, I feel like we really need to make parents aware. I mean, some of them are. I know we've, you know, you've talked about all the progress that we've made with doctors. You know, limiting their prescriptions. You indicated you prescribe a lot less. I have been to Sports Medicine North for a couple orthopedic injuries, and before they'll treat you, they have a 5-page contract, basically, on their policy for prescribing pain medications, and you have to sign that before they'll even see you. They're very strict in how they do it. And I mean, it'd be great if all doctors did that. But I've heard too many stories from families that lost kids because their first taste was that injury, that sports injury, or whatever. And, you know, instead of being given that small amount of pain meds, they were given, hey, well, here's your 30 Percocets or 60 or whatever. And kids, you know, adolescents, hey, this makes me feel good. You know, they, unlike you, because you're an adult, you're older, and you're wiser about, hey, I don't want to stay on this stuff. They're not looking to wean off of it, most of them, you know? So, and for some of them it takes, I've talked to recovering addicts where it was one time that they were prescribed something and they love that feeling, and, you know, I know a woman, she said, I have to wait 4 hours. Well, maybe I'll take it in 3 hours and then wait longer. It's like this game they play, you know, and the next thing you know, they're hooked on it, especially if they've got a genetic predisposition that just makes them a more vulnerable population. So, anyway. But I agree with everything you said, certainly. I mean, it's...
No, thank you, Libby. And we're very sorry to hear what occurred, the loss of your daughter.
Yeah, well, I mean, she passed away in North Andover. She went to the high school. She was a kid that didn't even drink in high school. She suffered with mental illness, and early on, one of her psychiatrists had convinced her, if you drink, you'll get very sick, so she didn't. And she abstained from going to parties where she knew kids were going to be drinking, because she said, I'd just be holding people's hair while they throw up. You know, so this happened later, but the education wasn't there at the time. Unfortunately, she got off her meds as she was older and was self-medicating at one point, which led to the heroin. Started with pills. I think she went back to Percocet, which she had from the wisdom teeth, and was buying illegally, and then eventually made her way to heroin.
Yeah, there's not a lot of you can do on the heroin. Nobody's studying that and trying to reduce its effect on the opioid receptors, but just FYI for like Percocet and other drugs like that, I read an awful lot still on pharmacy and drugs. There's a research going on there now where they've isolated, nothing's out yet, but they've isolated the mu receptor is an opioid receptor in the body, and that's what's stimulated most of the time when there's other opioid receptors, but it's one of the more prominent ones. It's in the intestines and the periphery and so forth. But they're going to, down the road, come out with drugs that will stimulate another area in the mu receptor that will not cause the respiratory depression in the brain, which is what causes people to pass away.
Right.
Most of the time it's the respiratory depression that your body just stops breathing, and that's the end of it. So they are coming out with, you'll get the pain relieving effect, but without the respiratory depression. So I've read
good.
what I could on it. There's not a lot yet, but it's coming, I hope.
I know they're working on some new drugs, you know, along those lines, as well as better drugs to help with withdrawal, too, that aren't opioids. I also belong to, I don't know if you're familiar with the Addiction Policy Forum. It's a national group. Our state, I know the person who's our chair of our state chapter. It's a newer organization, but they're partially funded with some of the pharma money, but these are companies that are doing just that. They're working on alternatives. They're working on other, you know, drugs that, I mean, they weren't the ones that were selling opiates, put it that way. But so I get their emails. I can share their email address. They send stuff out all the time. They're a very well-run group. I had the opportunity to participate in their family days in April, where we met with our legislatures. I got time to meet with their staffers and our legislators here and find out what they're doing and, tell them what we feel is important. I always tie in the mental health component. I mean, you can't leave that out.
No, thank you. No, thank you for sharing. But I also want to throw out there, maybe you could give us your thought, because you're dealing with it now, and you're going to be the president. Now that the state has approved legalized marijuana, another product on the market that can cause somebody to lose focus, lose reality, another distraction while you're driving and so forth.
Oh, yeah.
Have you seen? What have you seen with have you seen anything with cannabis or?
The presentation, I know Brian went and Caroline went last Thursday. Dr. Ruth Pote presented, and she is a family physician, but she's certified, board certified in addiction medicine. And she has a presentation that she does, and part of it addresses cannabis. And basically, the big problem with our youth is that their brains are still developing. Well, you can correct me, the cerebral cortex and all of that, and it interferes. I mean, it's a problem. The studies show that, to your point, you were saying like 12 to 25, if we can keep, which is, maybe a stretch, but if you can keep young people from using any substance until they're 25, they only have a 1% chance of being addicted. If they have a family history, if they've got the genetic component, it's 5%. But the earlier they start, the closer they start to 12, it's like 50 and 4. I mean, it's big numbers as you go along. And even, isn't
I
it?
think what you said was if an adolescent by the age of 14, if they try nicotine, cannabis, alcohol, they will be 5 times more likely to have a substance abuse disorder when they grow up.
Right.
And by delaying that first initiation into cigarettes, vaping, cannabis, by the longer you delay that, the higher percentage you won't have an issue later on in life becomes. So it was very kind of eye-opening when she said that sort of target.
I know. That was one of the, I think, for a lot of us, one of the biggest takeaways.
I think it's a great point because it's really what we're trying to accomplish here. I think that there's a need to have a constant contact with people in that age cohort to make sure that look, I mean, kids are going to smoke, they're going to do these things, but what we want to do is we want to basically do the prevention as best as we can, and we can't do that if we're not continuing to talk to them and to contact them and reinforce the message.
Right.
How did we win on smoking, over the last 35 years? We won by making it expensive.
It was a great campaign, too.
We won by limiting its availability. We won by basically making it socially less acceptable.
Well, I think when I was in school, I mean, this was been the 70s. I just remember the campaign against smoking. My parents smoked. My sister and I used to go around and make little cards and put them on their ashtrays about cancer, So the kids were on board before the parents were. Now, my parents luckily stopped smoking about 30 years ago, but, and a lot of families, I think, unfortunately, you have parents like, oh yeah, we used to smoke pot and we drank and we're fine, or even do other drugs and we turned out okay. But this isn't your parents' pot or your grandparents' pot. I mean, this stuff is incredibly strong. What is it, like 100 times? Some of it's like 100 times stronger?
It's 100 times stronger than
so potent.
Oh, and they can vape it now and you don't even smell it.
I know,
Yeah.
I know, but I mean, it's still,
And the success that we've had with the tobacco campaign, reducing adult nicotine use by 60% in smokers, is now being undone with our next topic, which Ron's going to talk about, vaping and e-cigarettes. That just is spiking and bringing it right back up.
It's horrible.
And canceling out 30 years of public health.
Right.
Frank and I gave a talk about the public health effects in front of one of the town boards about the public health impact on the state legalizing marijuana. So we were there about 20 minutes giving. We used as our one of our guides, in Colorado, they every so many years have to do a huge assessment on the effects of the legalized cannabis from various age populations, the foods that it goes into, and hospital admissions, and whether or not it goes into breast milk and so forth. And it's not really working out like people thought. It's a drug. There is addiction, they find. There have been an increase in hospital room admissions. There is a danger. It does affect your brain. So I don't know why this is good. I don't understand why states would okay another substance like that. Again, we're not here to, we can't change it. This is
Right,
fact.
I know,
It's going to happen.
I know, yeah, and Dr. Pody
But
was...
it's part of addiction.
Dr. Pody was very upset that the state had not done this additional research. She felt that they just ignored some of the medical research about the effects.
Right. Right.
What bothers me is you'll probably have the proliferation of all the edibles that look like candy.
Exactly, yeah.
And
Yeah.
I would like to see somehow to have them marked in a certain way, you know, whether it's like a black line or a big black dot, something, you know, so that, well, you know, you could just see even adults could innocently be given something and you don't know because the person didn't tell you.
I think they've made it so that animal shapes are illegal, but that still doesn't matter. You can still make
No,
them look like a
it just,
gumdrop.
and they have so many things that are.
So you can't make it look like a
They're
gummy bear.
imitating like other candy bars, they're
Yes.
imitating existing candy and cookies
Correct,
and
yeah.
things. So, I mean, you'd hate to have your, you know, your kid, even if the parents in the household, oh, yeah, they're consuming it, well, what about the kids? They get into it, or, you know, their friends? I don't know, I just see a lot of,
It can still be
issues
shaped
with that.
like anything else. It can be a lollipop
Yep.
right?
and whatnot. So
Yeah.
I know in Colorado in that report there was a lot of, there was a section on the increase in poison control calls from,
Yes, in
Kids eating edibles
Colorado,
by
and
accident.
an increase, I believe, in the ER admissions of
Yes,
kids
yeah.
that have ingested things, yeah.
Yeah. No, thank you. I appreciate you talking about your experience and sharing with us. Thank you very, very
Oh,
much.
you're welcome.
Is there anyone else in the audience that would like to add something to this, or a question, or share something? It's okay.
I think we'll have to gear everything that we do still towards the old tobacco model to reduce and
Yeah.
education, prevention, reduce the use from an early age.
Yeah. Okay. Dr. McMillan, thank you very much.
Thank you.
Much appreciated.
Happy to start the discussion. Because there's more to say.
There's
Yes.
always more to say. So now it gives me great pleasure to introduce Ron Beauregard. Ron, I didn't have your business card, so I couldn't give you your title, where you work out of, or what you do. So maybe you could just tell us a little about what you do in the state and why you're here today, and then your presentation on vaping.
Thank you, Mr. Chairman. Ron Beauregard, proudly working on behalf of the North Andover Board of Health since 2001, as a tobacco control unit, and I'm based out of Andover, and we work with a collaborative of 18 communities throughout Merrimack Valley and the North Shore. I do have actually a question for Dr. McMillan. It's just a real general one, and anyone else that would like to kind of help out. One question I have is, when everything is focused on prevention as being the key, the best, the most efficient method of controlling addiction, and adolescents being the primary risk population, why does there seem to be a impediment for funding to properly fuel that effort? What I mean, you're in the medical community. There's in what you start in Dr. Trevor, and you started with, and I'm wondering if the beginning of your presentation focused on the misdirected view of what addiction is, a character flaw, some sort of tough love to get out of it. What is that? You think it's because of the remnants of that misguided view of addiction that causes us, or is it that we don't really know exactly how to communicate the ideas to get to the prevention?
So I'm not a child life specialist, I'm not a pediatrician, but as the father of 3 children, and as the victim himself, once a child, there is something very unique about the way a child, when they go through adolescence, it's very normal for them to be risk-taking. And that's something that you don't want to stifle. And so you have to find a way, so I'm not going to answer your question, but you have to find a way to understand that it's normal for a child to take risks at that age into their young adulthood. If they didn't, they would never grow. So, but it turns out that the temptation of the substance use issue kind of comes on at the same time, and it just hijacks them at an age of vulnerability. And so I don't know how you get through to them. I mean, short of corporal punishment, my kids know where I stand on these things, but that doesn't guarantee the outcome. They're going to do what they're going to do what they're going to do. But I try to approach them in a way that, it's like, you have an opportunity for a great life. This is going to hold you back. There will be nothing but tears from certain types of bad decisions. And those bad decisions include lots of things, whether it includes early pregnancy or physical violence or, just all the things that kids are at risk for, bullying. It's just that, don't mess it up early on because it's hard to recover from.
I suspect that your answer might be something like that.
I was going to say, I was reading something about addiction and talking to your kids as well, and I think some of us don't realize how early some of these children are exposed to some of these substances. And one of the things I read said start talking to them 3rd grade, and I mean, which is so young because I have a child going into 3rd grade next year, but at the same time, I mean, if they're being exposed to this 5th, 6th grade, you want to be the first one to kind of set this, this is what I feel, this is what I believe, this is, what might happen. And so you're maybe the first one talking to them about it is one way to kind of look at it and hopefully get to them before, the substances do. Yes.
I also think, the state of Massachusetts spends about 20% on prevention and 80% on treatment, but I think it goes to the rest of Frank's presentation was really about the fact that are we doing treatment effectively? So if the average relapse is 14 times and what the cost of each one of those 30-day treatments opposed to having a 5-year progressive follow through, and if we were treating it as chronic opposed to acute, I think that's one of the challenges. Are we using that 80% in the right way? Because I think if we were, then hopefully you would see some of that 80% shifting into the 20%. I mean, that's just my personal theory.
I'll give an even more jaded perspective. Kind of what I've seen on stuff like this lately is that research and evaluating problems is expensive, and anybody who's going to fund research wants something to come out of the other end of it. And we see this in drug research also. So researching prevention, unless the government is going to do it in a purely, what's the right word, altruistic mode. Prevention is prevention. It keeps people out of something, but there's not a product at the other end of it. Whereas, like she said, when you're treating a patient for drug addiction, there's a drug to be sold. And if somebody develops a better drug, then when patients cross that line from, again, this is jaded, this is not sort of how I practice, but there's some reality of this, that when you go from preventing to treating, then there's treatment that's a drug, a product, something that's being sold, whether it's under insurance or Medicaid or whatever, that somebody's buying something at the other end. So there's a real commercial-driven basis to a lot of this stuff. But also what we see is, and I see this in patients who I see who have been in sort of this addiction world, is when you go from prevention to treatment, the resource utilization goes up tremendously. The amount of, like when Frank talked about the treatment of patients in addiction, it sounds simple, but when you get patients involved in that stuff, the commitment to that by family, medical community, government, everything becomes astronomical. And that's what, I'll give a plug for the town. We're putting a little piece into that. We're getting someone along the line of a social worker to help plug into that, because today physicians, the way that physician's practice, there is not a lot of time in a usual physician's day-to-day practice to commit the time needed to get someone through those things that Frank talked about. There's got to be more coming down to it than the primary care doctor and somebody in the family. There's got to be a multi-contact network. It's a whole different ballgame when you go from prevention to treatment.
Ron, I would say though prevention works, and we actually have cigarettes to prove it. And getting the machines, getting them out of the machines, getting them out of the pharmacies, making them not cheap anymore. And I know you're going to talk about this when we get to vaping, but a pack of cigarettes is over $8 a pack. There are a lot of kids who can't afford an $8 a day habit. That's prevention right there. Now it's blunt prevention, but you've decreased access by making it inaccessible, by making it expensive, and so those things work, and the data is there. It did work.
Yeah, I mean, the way I always like to summarize is prevention. It seems so obvious and yet elusive at the same time. So
well, I think you have to think about how you're going to prevent it.
I haven't seen some of the stuff you talked about, Larry, but I think that's some of the discussion on the marijuana thing is taking it away from underground and making it available in the above black market, and making it readily available, but then controlling the access and the cost. But again, you said it maybe isn't quite working out that way. So, you know, it's a little bit of a runaway train now, I think. But
what you said about give and take, I'll develop this drug or I'll do this research, but I need to sell something in order to do it. Well, I've been reading about cannabis in the states that are active in it, and the major investment from overseas, mega billion-dollar companies are wanting to come in here and supply these monster cannabis producing whatever they want to make. There's money. It's going to be bigger than the cartels if they can. It will be bigger than the cartels if they can get marijuana legalized in the entire nation. It'd be a disaster. Just a disaster.
The problem is that there really is a free market in drugs in the black market. You don't really have a black market in cigarettes. You do. Kind of that guy in New York got choked because of it. But it's not that big. Most people won't buy cigarettes on the black market. But there is a black market in marijuana. So if you tax it high or if you restrict its access, the black market's going to say, wonderful, more business for us. And so
it's a competition.
I think that there needs a little bit more thought as to how to do it, and just bringing it out and saying, okay, we're gonna tax it, we're gonna distribute it. You know, you have the same problems that you have with alcohol. Well, how many licenses do you have in town? And you know, it's not a simple answer. But I think that the model, that the tobacco control model, is there, and we can borrow from it because we know it's effective. We just have to be creative about how we're going to utilize it. And I don't have that answer about how you do that. But
well, that's a good segue to the vaping, because I feel like, and you had mentioned, Brian, that we're kind of repeating history now. It's sad. We have had a handle on traditional tobacco, combustible tobacco, cigarettes, cigars, etc. What I'll do is I'll just try to give an overview of the amount of use of vaping products, also called electronic cigarettes, also called nicotine delivery systems. I'll also give you an idea of what's in them, and what the health consequences are, and what policies and education we're implementing. We are funded by the Department of Public Health, so we have that support to help us try to tackle this. Excuse me. In terms of use, vaping is now dwarfing the amount of smoking that's occurring in the high schools. The vaping rate, and it's usually measured by, they have these surveys that are applied to high school students, and in the last 30 days is usually the question that's used to determine whether somebody is currently using a product. And with vaping, it's now, the Department of Public Health statistics show the last survey that 24% of high school students have used electronic cigarettes, vaping products within the last 30 days, are regular users. That compares to a cigarette use at 8%. In fact, the rate that high schoolers vape is higher than all tobacco products combined, all other tobacco products combined, so whether it be cigars, cigarettes, chew, or snuff. Even more alarming is that about 45% of high school students have tried it at least once. And this is versus a 4% rate for adults. What they are, pretty straightforward. It's aerosolization, vaporization of a liquid through a heating process that doesn't burn, but heats a liquid sufficient enough to deliver both a flavor and usually nicotine to the person using it. And of course, I'm not here to particularly malign any particular brand of these devices, but one name that keeps coming up, because I work with the retail community, over 360 retailers, many of who carry this product. And it's pretty well known that this Juul product is one of the most common, if not the most common, in the high school. This product is inconspicuous, usually, often held, very easily in the hand, and looks a little bit like a flash drive, and I'll kind of pass it around if you haven't seen one. But the way they basically work is they're charged on something that just goes into your laptop in here, and sometimes they've been mistaken for like a Wi-Fi antenna or something. It's a magnet. And what this does is it charges in about a half an hour. And when you put the pod in it, and the pod is the device that, this one happens to be mango, and I can tell you that, at least in this particular brand, there's mint, there's mango, there's fruit medley, there's creme de brulee, and there's traditional tobacco flavor. I'll pass these around as well, but basically the way these work is, again, it's just a very small pod. There's a cover on it. In this clear portion here is the liquid that you'll be able to see, and then there's a microprocessor. The other end is the actual part where you would put it to your mouth to draw from the vaporization that occurs. You just simply take this and snap it into place, and it's ready to go. I think I charged this one. Yes, I did. So a green light, you tap it twice, and you'll see the green light go on. That tells you have a full charge. If it turns yellow, that means that the battery charging is going to be necessary at some point, and then red means it's either not going to work or about not to work. If I were to draw, it would just draw right now. This one is particularly troublesome for the schools because the vape that's produced generally is what I'm going to call a disappearing cloud, as opposed to what many may see with the pods, which are used with the liquids, where there's two ends of the spectrum for vaping. There's one inconspicuous with, and oftentimes a high nicotine delivery. This little pod that I inserted contains as much nicotine as an entire package of cigarettes. So what's troubling about that is there have been incidences of nicotine poisoning. I think most, even among the youth, they're cautious enough to know that, you wouldn't want to use a whole one of these in one sitting, or even in 2 or 3 sittings. But the scariness about them is they're not. If someone ever told you to smoke a pack of cigarettes in 5 minutes, it'd be, like some stunt. You'd probably get so sick. It's just too many chemicals, too much combustion, too much smoke. It makes it impossible. Whereas something like this, other than the obvious effect of the nicotine hit, they call it a throat hit, this makes it a little more of a, I guess, a scary proposition. So I'll pass this around just so that you know what it looks like.
Ron, what is the
How does cigarettes too, Ron?
Cost? Yeah, sure.
Thanks.
The cost, I purchased that for $30-something. They're usually right around in the 30s. They can go a little over. It depends on the particular retailer. And then the pods themselves These, you get, and I'll pass these around. The pods, there's 4 to a package. There's no mincing words on them. They do tell you that this is roughly equivalent to, one pod is equivalent to a package of cigarettes and the nicotine level. This is the mango, and you're more than happy to open up another. The one that's opened up has lost a little bit of its strong of the scent. These haven't been opened yet, the mint.
And what do those pods cost?
The pods cost anywhere between $15 and $20.
For 4?
For 4.
So it's less expensive than cigarettes.
That's correct, yeah, that's correct, yeah. That's one of the selling points.
I know.
And even less expensive is I can't just designate the youth as the only, but if anybody goes on to YouTube and just puts refilling a pod, a jewel pod, there's injection methods and that sort of thing, and of course, other liquids containing other chemicals can be inserted in there as well.
How much did you say the pods cost?
The pods here usually are somewhere between $15 and $20.
Ron, how long does it take to go through a pod? So let's say I go buy one of these, and parents out there, folks watching, this is really dangerous. I mean, this is legalized drugs the kids are enjoying. This looks like fun. Ron and I were talking, Frank and I have been talking, we've all been talking about it, but it looks like a fun thing to do because kids like to play with electronics. They like to see a green light or something like that. It looks neat. It's from Ron and I were talking. It's cool. This is cool to do it, and I see this as when.
This has a pleasant odor, I have to say. This is what flavor? Cool mint.
Cool mint, yeah.
I just want to show. How long does it take to go through a pod again?
Well, I can't talk a personal
No,
history
but
here. And, no, I'm sorry, Larry.
Larry's
And I
got
haven't
After
Don't try that stunt.
Have a band and tie them together, we'll get a blowtorch and light them all up at the same time.
You just ruined Ron's,
That's okay.
Sadly, we have plenty more.
Wait, that's $8 worth of smokes.
No, I just want to show the parents out there and the kids watching, I want to show you what it looks like when one of the kids go through one of the pods, right?
And you can just pull out the pod. I mean, it's literally that little pod, just a little bit of juice that you see in the pod itself.
It has the same equivalency as a pack of, hold on, there's 2 more in here, as a pack of cigarettes, right?
Yeah.
Can you imagine smoking a pack of cigarettes? And I don't know how long it takes really to go through these. I have no clue. But how fast you can smoke a pod, I don't know. 10 minutes? I have no idea.
The observations I've made in regard to the Juul is most are drawing 2 or 3, maybe 4 times at a session. I don't know how I do here, and this is a more anecdotal, and you will get better information from the schools themselves. But I visited the principals at school systems and health teachers, and the worry is that, and this goes to your entire presentation in regard to addiction, is it goes from something that I think it's cool to something I need to have. And because this particular product is inconspicuous, there's numerous accounts of not smoking in the bathroom, as the song used to say, but of vaping in the bathroom. And it's really a big, big problem, and a big problem for addiction. I mean, not only just confiscation of the devices, sales, North Andover was in the forefront of actually implementing policy. You were among the first 6 in the state to implement that policy to restrict flavored tobacco, which includes vaping. I mean, there are thousands of flavors once you get into the other pods and other devices that are used to use nicotine. You, fortunately, in North Andover have that restriction, and it's not the only answer, though, because there's online sales and there's, of course, purchases from students that then sell them in the schools. So,
when Ron and I were talking about this, I didn't realize it was so technical and could be so much fun to play with, because I think that's the way kids are looking at it.
Some would call it the iPhone of
Right,
of
and,
vapes.
and we were talking about, to me, this is the new beginning of tobacco in the United States for introducing it to our young ones. I mean, that's the way I'm looking at this. Hell, I almost want one. I mean, they look like fun. It's terrible. So I wanted people, if anybody's watching, just to show you again, one of these units equal all of these. Not good. Very, very deadly, very dangerous. Ronald Reagan used to promote smoking is good for your health. If you have gray hair, you'll remember those commercials.
Well, and you actually touched upon one of the biggest frustrations that educators have and prevention specialists have, and that is what I call, and what I hear from the students and from health teachers and other administrators, is what I call the false choice proposition. Many students are lured into the idea that as compared to cigarettes, these are safer. Now, we've always really been guarded against that word safer. I mean, for the longest time, the manufacturers of snuff and chew tobacco, most people know that, you know, the stuff to put between your cheek and your gum, or wad in your cheek, the chewing tobacco, that it's less dangerous. And there are folks who really are very learned in the area of harm reduction that could make plausible arguments to a board like yours about, while not safe, they are a better substitute from combusting the tobacco. The problem...
Well, Ron, that's sort of, I've seen some research coming out where it's not an apples and apples kind of a comparison, but these are being now shown to come out with other chemicals that are
Yes.
that are ingested and are just as dangerous. I think I saw something came out from the AMA recently that, I think in JAMA there was something published that I think benzene comes out of this.
Yes.
This is not,
And formaldehyde.
this is not a benign alternative.
You might be
by any
referring to that study that journal...
It's also the substance that causes popcorn lung.
And that's diacetyl.
Diacetyl,
There's two different
yeah.
things, Doctor. One is what you mentioned from the Harvard School of Public Health, which focuses on, is a fellow that works for the Chan, as a professor at the Chan Harvard Public School of Public Health. And formaldehyde is something they found in a majority of the product. I think I actually have it here. It's, yeah, in more than 75% of vapes and refill liquids, and that was from a study by the Harvard School of Public Health, contain diacetyl. Now, diacetyl, it came in the news a couple of years ago, where folks that were working at factories that make microwave popcorn, that artificial butter flavoring, diacetyl is used to help in that process of delivering the flavor to the popcorn. When you heat it up, it produces what they, actually there's a clinical term for it. I've always called it popcorn lung, but it's bronchiolitis obliterans, popcorn lung. It's a deterioration of your lungs and your lung respiratory capacity. So these are contained in actually, the state of California has noted 10 chemicals, including nickel and lead, and again the formaldehyde, benzene, all are contained. That false choice thing that I'm mentioning, everyone is talking about that. The teachers are being confronted with that because students, as well as, you know, maybe having an inherent risk-taking period of their lives, are also, they're not fools. They understand the difference between a cigarette and a vape. They also don't understand some of the things about the vape itself. But the one thing they know they can tongue-tie professionals even with is, can you say with 100% certainty that a vape is equally as detrimental to your health as a cigarette? And they know they can't get a positive answer from that person to try to answer the question. And that's why I asked you a question about prevention, because it seems like the approach by which is taken to communicate with students about this not being safe, and the only way that I, in my very humble attempt to do it, is I work with students, of course, because we do the compliance checks. And one thing I'm very proud that I'm able to do is once a year, which we just did a couple of weeks ago, we there's a thing called Kick Butts Day that the Department of Public Health has an arm, an education arm, and it's called the 84, and it's a youth group that are active in many high schools throughout the Commonwealth. And what they do is this once-a-year thing, and I'm lucky enough to be part of a program that accompanies them to legislators, and they educate them about what is going on. And the thing that they seem to focus on is we don't want to be manipulated. We know we are being manipulated, and perhaps, I mean, in that they're a target, a marketing target. And that's not an unusual concept. I mean, we're all targets. I mean, I know when I go onto Yahoo, I have the kid kneeling in front of a tombstone, you know, for me to buy life insurance. They know what my age range is. There's a variety of other products and such. Everyone's a target regardless of what age and what you do. If you decide to get into a sport, you're going to get all those advertisements. Well, the students, what I've tried to communicate with the students in my limited involvement in this is, well, people want you to wear certain clothing, shoes, want you to eat a certain food, want you to buy a certain song, want you to buy a certain electronic device, whatever it is. The big difference between those products and these products is, and this is what I think makes this the most insidious, is this contains an addictive drug. This you could carry with you for the rest of your life. You have to pay the folks that make this. In order for you to get off of this, you're going to have to do the treatment that you had mentioned. That is different from getting tired of a food or getting tired of a style of clothing or realizing this particular phone blows up and I don't want to have any part of it, or whatever it might be, whatever it is that's a problem with a product. I, of course, work with many, or meet with many vape shop owners and smoke shop owners and just general retailers who carry these products. And of course, they talk about how certain studies haven't proven things, but the ball is certainly moving everything's moving in the direction that they're extremely problematic with these chemicals in them, not to mention the toxin, nicotine, and the addictive toxin. Most that are in the business, I'm going to tell you, I do believe, have a genuine nature to them in their belief that vaping has helped some of their clients, and often themselves, quit smoking. I'm not here to malign someone who believes in it, even if there's no proof by the FDA that these, and there's nobody has been successfully applied, by the way, for approval by the FDA to use these as a cessation device. So that gives me a little bit of a hint that that's not the direction that they want to go with it. It's not to help you just generally quit smoking, but it's to help you generally keep vaping. But they point to that, and I give them that. You know, if someone has tried all kinds of methods, the patch, pills, gum, whatever it might be, and they use this and it works, there may be some science to say that they're taking the slight harm reduction. But that's not, we took a look at the statistics, and it shows that adult use right now is at about 4%. So you have students that are using them at 24%. There's the real market, the driving market, are the youth. And there's no spearheading I see from the industry to do whatever they possibly can to use the funds that they have to limit this to just those who want to quit smoking. And I find that troubling. By the way, just I brought a couple other products, but this is the one I wanted to show you that I was alarmed to see. These have been popping up throughout the state, and there's no exception in our area. I purchased this, it's called Blue, My Blue, for a whopping price of $1, okay? $1.04, I think it was, or 6 cents, including the sales tax, at a convenience store. Blue used to be, and I used to have samples, but they kind of disappear sometimes. I gotta make sure I collect, well, not the cigarettes, but some of my samples disappear.
Did I ruin your...
No, that's fine. It's the jewel I gotta get back. But blue used to be a cigarette-looking device and disposable, but now blue, not to be outdone by Juul, has their own. It's, boy, I'll tell you, I don't know much about patents and that sort of thing, so who knows? There's probably some legal battles going to occur, but this looks surprisingly similar. And this one just, same clicks. This one charges a little differently than the method I showed you there. This one charges by putting it in here and then with a cord into your computer or charger. This one here, when you do, I won't demonstrate it here, but it doesn't have the nifty little tap thing. They didn't, maybe they couldn't take that. But when you plug it in, when you do plug it in, it'll either turn green, orange, or red for the same indicators as the blue. In this one, you can smell this one. It's harder to, I'll get your survey on what you think it smells like. It's called gold leaf, which this is permitted for sale in North Andover. I haven't noticed yet in any of the stores in North Andover whether they have them or not. But as you recall, with the flavor restriction, you are allowed to sell tobacco-flavored juices. And this one is, I guess, sort of, it has this gold look, is the usual look of tobacco flavor as opposed to other flavors. But I don't know whether it smells like tobacco. You can make your own judgment. You can just pull it out and smell it. Try not to handle the part there with the liquid. I even bring gloves. I bring gloves sometimes because we don't want you to have nicotine juice.
Did the whole thing cost $1?
Yes.
The entire.
Yes.
Well, the pods must be made to only fit that blue container then. That's
Yes.
why they're, it's like, I'll give you the printer, but you have to buy the ink.
That's right.
Yeah.
That's right. They'll give you one, ink cartridge, so to speak, yeah. But that's it, once you get started.
How much are their cartridges?
That I don't know. I haven't yet gotten the, I don't know yet what the,
Ron, I've read articles in the past where the cartridges can be loaded with whatever you want to
yes,
vape. Is that true?
yes.
I won't ask you how they do it, but
That's right,
but
yeah.
it is.
I've watched,
yeah, we don't need to know that.
Readily available, yes.
That's even more. That's just.
First, it's to save money. It's kind of, remember with your ink cartridges, I tried it for a while there when I had a dot matrix printer. Yeah, I made a mess. I ruined a shirt. That killed some of the savings because I had to buy a new shirt. But yeah, I had all that powder that you put in there and such like that. But these usually is some, a needle of sorts, and it's cheaper, to fill them. And then lastly, the thing I brought was all of these products, other than the Juul device, were all purchased thanks to sales to minors. We do the compliance checks. And so one of the things we're focusing on now more is if we know a particular store sells Juuls, we're gonna ask for Juuls. It's a kind of a budget buster a little bit because we have to pay $15 to $20 for it instead of a $2.50 cigar. But we have to do what we have to do.
Surcharge on the ticket?
I don't know. That's not a good idea, Brian. This one here, it's almost like it's like an extravagant thing. This one here cost, we didn't put the price. My memory of this one was about $25. Purchased at a vape shop. And it's like you're buying this extravagant, product. This one is called, it's Moo Series, and it's called Strawberry Milk. And if you're careful, you can do it. Maybe you can't. Yeah, there you go. Oh yeah, just be very careful not to spill this on you if you. But it is kind of a.
And then what did they do?
Oh, well, this here is it's just like a dropper method here to fill the compartment for your vape device, which I don't have any here. But yeah, I would just very gently, if you're going to open it, don't spill this on you.
So I know this sounds like an awful way to try to do something about this, but it almost seems like if adults started using it, the teens would stop using it. It's like Facebook,
Exactly. I don't want to be like Mom and Dad, yeah. It's a very interesting take.
That's actually a great suggestion. Maybe next meeting, we'll all just start
Yeah,
vaping
yeah.
here. And like, look at these like 5 like super uncool people.
Yes, when the parents, they abandon it, right.
Teens don't want to do what their parents do.
Oh, yeah.
You know, on these vape devices, what's the position of the state?
The position of the state, and you've adopted that part of that position, is they regard these as a tobacco product. That was kind of a revolutionary thing, again, when you adopted this, but now it's not so revolutionary. The reason why we regard it as a tobacco product and why we can do compliance checks and restrict their flavors is because most of the time, the nicotine that's within them is extracted from a tobacco leaf. You can make it synthetically, and I've talked to some vape shop owners that have some products that have synthetic nicotine, but even those are covered. In fact, under your regulations and the regulations that are the model that are promoted by the state, even vape products without nicotine, or purportedly without nicotine, are covered by your tobacco control regulations. There is a bill in the state legislature right now to do what you've already done. It's the really small, significant, but not nearly as extensive as what your board has done, and that is it would prohibit sales to minors. Technically, the state law right now does not prohibit sales of vape sales to minors. It would also prohibit vaping wherever smoking is prohibited. So, and that's one of the problems with the more like the Juul-like, and I don't know enough yet about blue, but these ones that don't, where the aerosol, we'll call it smoke, dissipates very quickly. Those are the things that are most worrisome because they are just done in, whether it be at a dance or whether it be at a restaurant or a bar. In fact, before I came here, I looked at some YouTube videos that use that as a selling point for these products, the Juul products, because, well, where you really can't vape, you can vape, you know, whereas, you know, if you go chugging along with what this produces, you're going to be like, kind of like Pigpen, you know, and Peanuts. You can't be easily disguised. It's got a cloud around you, so.
So, Ron, two things. First, I want to give Frank a plug, because, Frank, you brought it up about the vaping and about having Ron come in, so I want to give Frank a real plug. This is a great topic that we're talking about, so.
I don't know
kudos.
this stuff, so I invite my expert friend.
Second, what on earth, listen, adults can do what they want. We're not here to tell an adult you can't do this.
Yep.
But when you have, I don't know how young you've learned kids that are vaping. I don't know how young it's gone, and I'm sure it's in the high school and so forth. I hear it's horrible there. I don't have any children, so I don't have that information. But I guess, no, our job is to help maybe come up with a way, well, we have our rules and regs, but how on earth do you get control over this in the school when you can't see it? And it looks like a nice electronic device.
Well, one of the things, and again, it's not my specialty, but I wanted to make sure I noted that Diane Knight, she's the director of the Northeast Tobacco Free Community Partnership. I can never remember how to say that, so I have to look. But she is actually, I asked her, I told her what I was going to be doing today, and I said, Diane, have you been in North Andover as of late? And she's already made 3 presentations to parents and to school administrators. She went to the, I'm having a deja vu, by the way, Dr. Trevor. I remember when we were going over our regulations, I couldn't read them on the thing, and so I'm getting to that, it's getting to that time of the day where glasses might be necessary, but to the regional school nurses at the North Andover High School, she's spoken to them, to the teachers at the Brooks School, and to the teachers at North Andover High, and she's scheduled to speak with the North Andover Middle School teachers on June 6th. She's a great resource. She brings a lot of these products. And, you know, my only, you said the word, Dr. Trowbridge mentioned the word jaded. You know, sometimes folks like us, we are called in because everyone says, there's a problem, there's a problem, there's a problem. And so you bring us in, and probably giving this sort of away, or maybe it's apparent, but we basically say, You're right. There's a problem. There's a problem. And let me get more detailed of what the problem is. It's even worse than you think. Here are the health consequences. Here are the percentage that are using it. And then usually people ask us, which you've been kind not to yet, although you sort of have, is, so what's the solution? And that's why I actually asked you that question before I started, because I'm not a prevention specialist. And I mean, I'm around it, and I get an opportunity to participate, you know, communicating with students and such, but you know, everyone seems to have their own sort of take on the approach.
Right.
The one thing that seems, oh, and I did bring an ad. I don't know if you really want to see it. I know I've been on for a while, but suffice it to say that I could only find one ad. The Food and Drug Administration has I think it's called the Truth Initiative or something to that effect. I can't remember the exact wording of their advertising campaign, but I can only find one ad that they've produced, and I know students have seen this ad, and some regard it as very scary and eerie, and others, of course, that regard it as hokey and overproduced and doesn't hit home at all. So, you know, folks that are very learned in marketing, it's counter-marketing. That's kind of how we succeeded in curbing tobacco use among youth. It's a great victory to be down to 7%. We had, you know, I think it was approaching when we started around 20. So, but what's the answer? And one thing we do know is, in that group I mentioned, and if and I know Diane Knight mentions this, is this students getting together that know that the wool is, you know, being pulled over their eyes. They know that home manipulation thing. This isn't going to work, and if it's not the answer, it seems to me to be a starting point, the energy, the way to convince, to persuade, and to make something that, I know your first reaction was, this seems cool, and it does seem cool. But, you know, someone once said to me something to the effect of, yeah, someone's trying to tell me to suck on this thing. And I don't know what's in it. I go, is it regulated yet fully by the government? No. Is advertising restricted like tobacco? No. What does it have in it? Well, it does. A lot of times the folks who are marketing it say it's got food-grade ingredients, you know, food-grade flavoring agents. Yeah, most of those studies are for ingesting the ingredient, not vaporizing it. Something happens. The Harvard study showed that the diacetyl, when you heat it, turns into a variety of other things, including formaldehyde. So trying to communicate that, but it's that whole risk taking.
The food additive is propylene glycol.
That's right.
It's a food preservative.
That's correct.
That, when ingested, is fine.
Yeah.
But when you ignite it, it does change its chemical composition.
Yes.
And they don't know what the results are and what the effects are. So yeah, it's a food additive, but you're smoking it. So it completely
Exactly.
changes it.
No
Same
one
thing
wants-
with the nicotine.
And the nicotine, yeah.
They don't have clear studies as to what the percentage of nicotine is in each component and
Yes.
each specific brand. And they say no nicotine, but they actually have nicotine in them.
That's right.
Some of them have been tested to say 0.0% nicotine, and they have like 5% nicotine. So even the packaging is wrong.
Everything you're mentioning, too, makes all of our work a little more complicated. You know, usually when you try to, when we're making sure there's compliance with the law of selling these products to only people of age, the students now, I mean, pretty much everyone knows what a pack of cigarettes is, and to ask for them is, once you get familiar with it, it's not very difficult, or a cigar. But boy, knowing the nicotine level, the flavor you're asking for, if they don't have, you know, strawberry milk, ask for, you know, unicorn blood, or, you know, there's all, I mean, there's thousands of flavors. I've seen bacon. It's just incredible.
Well, let me ask you a practical question, though, because I do want to ask you your expertise. We haven't visited our tobacco regulation now for 3 years. What can, you know, and I think that you're exactly right. You know, there's going to be, some of this is going to be persuasion. Some of it is within the power of this board, and our regulation is within the power of this board. Would you suggest that we open that up, and are there different parts that we should, that maybe need to be updated to the new reality?
Well, we've had some discussion. I mean, comparing your regulation among the strongest in the state. You did do something that was interesting with remember the pharmacy, which, and of course, the pharmacies today here, and of course, CVS voluntarily withdrew their sales of tobacco. I can tell you, by the way, that one of your pharmacies here continues to have what I believe was created by all of you in regard to having an opaque sort of a design to the cabinet.
Yep.
And it's still there. I checked that particular retailer, and they are in compliance with what I know in your regulations is a voluntary. It's an encouragement to do so. So it takes away some of that allure. The only thing that you don't have a smoke shop in town. You don't have a vape shop in town. They're popping up in many communities right nearby. Some communities, and I know that when you first dealt with this issue, it was something of, there's room for disagreement among it, but some of the arguments for a permit cap have gained some traction for a different reason now, and partly because it's driven a little bit by the acceleration of these sales, and that is Middleton, for example, has just about a month ago put in a cap where they initially didn't, and they had strong regulations. And the reason they did is they're on 114 corridor there, and they have a smoke shop, and now they have another, and now they have a vape shop, and now they have another smoke shop. And while it's a small community, I think it's roughly the size of North Andover. I might be wrong.
Not even
but
close. Middleton is much smaller.
much smaller.
Yeah, the physical size is.
What's
probably
your
about half the
population?
size.
30?
We're almost 30,000.
30, yeah. They're more half of that, huh?
Yeah.
Maybe, yeah. So, anyway, they got concerned about that. And they were, Burlington, Massachusetts has actually implemented a permit cap and then a cap within the cap. And the cap within the cap means when too many of the establishments are of the nature of selling many of these products, because if North Andover had a smoke shop or vape shop, they could sell all of these flavors. But of course, they'd be under strict regulation to say you have to not have a food permit, you can't sell anything that's food, you can only let people that are 21 and over in it, and your primary product has to be tobacco or tobacco related. Everything else is incidental. Andover just adopted this permit cap as well, not the one within. The only argument I could say is if you were to assess your community of retailers, many of which probably couldn't convert to a vape shop, smoke shop type of model. You know, if they're selling gas, probably isn't going to be something they can switch to. If they're primarily a grocery store, I'm kind of going through yours, but if they're a convenience store that sells liquor, they're not going to switch over. It's unlikely they'll give up a liquor license to switch. Probably not, I'm guessing. So right now, as it stands, it could be more sad. And I'm giving you this kind of, I didn't expect this question. I don't want to go on and on because I could. Mm-hmm. But there's legitimate arguments on both ends. The argument to say not a permit cap is let the market dictate it. There's going to be a saturation point at some point. How many smoke shops can you really have? Or how many vape shops can you really have? The other argument, though, to have a cap is, and those who criticize the cap are sometimes told that we have a cap for liquor establishments. Now, again, it can be you may disagree with that. When we had the pharmacy, we had that same debate about the pharmacy, that it was just really a choice of venue than it was reducing. I couldn't provide you with any facts to say that eliminating tobacco sales at pharmacies would actually reduce overall sales. And we have some places that have the pharmacy ban. Neighbors who are convenience stores laud the decision because they're right next door and the sales shifted.
I think our rationale for the pharmacy ban, though, was anti-normalization.
That's right. That's right.
That was our rationale. It wasn't so much to reduce the number, but was also to kind of create an environment that did not promote the normalization of tobacco use.
And CBS
that might be a
hedged it.
strategy that,
Yep.
that ultimately is successful with vaping. Right now, that there's a strong normalization that's going on, especially among the younger crowd, the middle school, high school crowd, that your argument about, getting peer persuasion might be very helpful for. But right now, it's a normalized behavior. It's expected. It's pervasive. So, I'm not trying to get too off topic, because I know that you wanted to make another point, but when you brought that up, it was very immediate to me, because I was a proponent of that. It's like, this is normalization, and this is something that we should be against as a public health board.
If I had that point, and remembered it, I'd tell you right now, and I apologize, I don't. And I know you've spent a lot of time on this topic, and I hope it's helpful.
It's very helpful.
And we're searching, any ideas, or, you want to meet and or call me.
Yeah.
I don't think anyone, the online sales is a big issue, and I know the Attorney General's office is likely looking at that. But you started your whole topic with adolescent is the primary risk population, and prevention is the most efficient way to do something about it. And I'm kind of caught in the middle of it a bit. I'm seeing all of this stuff, and I can't say I'm defenseless, but I have limited abilities to. I'm not a health teacher. I'm not a prevention. I'm not an addiction specialist. I just hopefully can be of assistance in, providing information and education on what I see. And
Our regs cover nicotine
Yes.
covered by,
Yes.
delivered by electronic devices. So that covers everything we're talking about now, including flavor.
I got a quick question.
yes,
Just curious as to what, not the exact percentage, but sales, regular tobacco versus e-cigarettes and vaping products. Do you see a discrepancy between a higher percentage of sales of vaping products versus your traditional tobacco? Is it skewed?
when you say, you mean of our compliance check sales or
Yeah.
overall sales?
Overall sales, when you go in and you get a violation, no matter
That-
where it is,
yeah.
do you see a higher number of vape sales versus regular tobacco?
I don't have a conclusion
Okay,
on
I
that
didn't
one.
know if
Yeah,
it was
I
like-
don't. We've just beginning actually to do this. It's
Okay.
about maybe a year ago. And so it's tough. And we also are governed by laws that require us to ask predominantly cigarettes right now. It's called a sign-our amendment, and we are responsible. It's part of the way that we get the state gets some federal funding, is that we need to comply with that.
So is there a way to increase the ability to try to do checks on vaping products?
Right now, no, just due to limited funding, I think. Yeah.
What I want
We'll
to,
work on that.
Thanks.
what I want to do is I want to find out if Libby or Cheryl or anybody in the audience would like to make any comments on this, or ask Ron or the board questions on this particular area. Libby? Please go up to the podium. Thank you.
It's just so that the microphone picks up your voice.
Now, I do have a question, because
Yeah.
my group does, we go to a lot of events, and we have table, we have a lot of information, pamphlets that we pass out to families about addiction, and I know it was mentioned earlier about talking to children. We actually have a pamphlet now about how families can talk to their young children to help to protect them from using these substances. But, of course, this is a timely topic, and I haven't seen any. So my question is, do you have anything that the Public Health Department's putting out, or that the state, because we have a lot of state brochures.
Yes.
Yeah. Because
Yeah.
I would like to have those for our next time we have an event.
The answer is yes, but there's something coming out within the next, I just went to a statewide meeting, and I believe it's going to be coming out before the end of next month.
Okay.
and they have a campaign, and I'm trying to recall, they got some funding to do that campaign. And it's going to be substantial, and it's something like the new nicotine, or the new face of nicotine, or something to that effect. There was a lot of study done with parent groups and such, what to use for wording of what these things are, and yes, there's going to be, in the next few
good.
weeks.
So how would I go on the website?
Yeah, either that, or you could call me. I
Okay.
will know.
Do you
I don't have my
card?
card, but I will give you my email
Okay,
address.
okay, we'll do that.
Thank you.
I have all his contact information.
Okay, good.
Thank you. Ron, what was, Cheryl, did you, by the way, I want to recognize Cheryl Barzak. Cheryl was a previous Board of Health member. Cheryl is a nurse in our school system. Please tell me what school, I don't know.
So I'm the Director of Health Services for all of the schools in
All the
North
schools,
Andover.
okay, I was close.
I wasn't prepared to talk this evening. I wanted to hear the presentations, and they're very, very great, so thank you so much. We are doing things in the schools. We were lucky to receive a youth opioid prevention grant 1 year ago. It's a 2-year grant. And so we implemented some life skills training in the schools. And so in the middle school, 6th, 7th, and 8th, we go over decision-making, especially with these type of products, as well as 9th grade. And we did just introduce in 5th grade a pilot in 2 elementary schools, the whole thing about marketing and how these companies trick you. And it was very well received. The 5th graders really get it, that they don't want to be tricked. And so by showing them how they market these products to them, I thought that was very effective. So we will bring that to all of the elementary schools next year. So you also mentioned Diane Knight. We brought her to the North Andover High School and had 40 lead nurses throughout the region hear her presentation about all the products. And there are just literature that we will share with everybody. But she also spoke with the high school teachers. It's important for all of the teachers to understand what the students are carrying around and what they are, because not everyone knew. It does look like a flash drive. We're bringing her on June 6th to the middle school teachers as well to, again, present the same information. So we're trying to get more information out there. I think the students don't understand the risks. Like you said, it's very fun. It's a nice tool. And as in the nursing office, when we have students that have used too much and they're not feeling well, they don't understand. They think it's okay for them because that's the message that's out there. So it's our job to educate all of our students that it's not healthy, it's detrimental to your health. And the addiction, it's very sad to see that now is going to start switching. We don't want to have our youth addicted to nicotine. We would, like you mentioned, having such great progress with cigarettes. The only other thing I'd like to comment on is with the other addiction. We have been conducting the SBIRT, the Screening and Brief Intervention Referral to Treatment for our high school students. We were one of the pilot towns in the state, which was great. So 4 years ago, we started that. And that gives guidance, nursing, and other clinicians the opportunity to speak to every single one of our 9th grade students and ask them the questions. And if they're not using, and answer the questions in one direction, to give them that positive reinforcement that you're making good choices, because it is about norms. And even with vaping, it's about 26 to 28% of our students. So there are 80% that aren't. It's okay to be part of the group that's not using these products, and we want to reinforce that, because that's important too, that social norms. Now, everyone's not doing this, so it's okay not to do it. And we just started the SBIRT also in the middle school per state regulations. So every 7th grader is also screened with an adult where there's no consequences. They can be honest and truthful with us. It's 4 or 5 questions, and then if they are having some addictive type behaviors, we reinforce with some motivational interviewing. No judgment. Do you want to make some changes? We can help you do that. There's no ramifications. You're not in any trouble at all, ever. And we've had some success with that as well. So we're trying. It's a large undertaking, but just a little bit of things we're doing at the schools.
I have a question for you. I'm sure that the school's student handbook, policies, manuals, and things like that all address tobacco use on campus.
Right.
At the schools. Do they address vaping?
So that's interesting. I'm speaking at school committee June 7th, and I think I watched their last committee on TV, and they are adding that to the handbook for this year.
So that's a school committee, not an administration function.
So the administration writes the handbook and the school committee approves it, I believe.
got it.
So yes, so we have the principal of the high school and middle school, and it's one handbook, and I know
I
that
was
that
gonna say,
language is in there.
uniform at the middle
It's
school and
uniform.
high school? Yes.
It's actually now going to be a K-12 handbook with some sections for the middle school and high school.
So it'll
So
be-
the penalties that are involved are similar to the tobacco penalties, so it's all
Right. And
lined
I
up.
don't think we want to focus on penalties, but it just, one of the things.
It's not allowed in schools.
One of the things that I had brought up was that, actually, I'm going to lose the thought that I had, but our own tobacco regulations are remiss, just because even in 3 years, there are things that we just did not anticipate.
Right.
And so, just from the point of view is not being directive on how to do things, but just saying that if your manuals and policies and procedures don't include these, then I think this is a wake-up call for all of us.
I know they just added them for this year.
Okay.
Great, thank you.
Thank you, Cheryl. Thanks very much.
Actually,
Ron, this is like TV. We go into commercial in about 25 seconds. You wanted to make one more point?
No, other than the fact that that presentation actually lifted my spirits. It's great. Thank you very much.
Thank you. This was an excellent presentation from Dr. McMillan, from Ron Beauregard. I think it was very successful. I learned a lot, and hopefully people watching and people in the audience picked up some pointers. This is a big deal. A big deal. So, Ron, thank you.
You're very welcome.
Much appreciated. Okay, so we're going to go down to new business, and we're going to talk about the Brooks School camp variance.
Yeah, I can speak briefly to that. So at the end of March, the state amended their camp regulations for recreational camps in Massachusetts. It was something they anticipated having done in the fall, and they didn't actually roll out and get approved until the end of March. With that, their training sessions, and so what just started like the beginning of April. So when we were in contact with our camps that ran last year, it was probably the first week in April, because we went to one of the conferences early on. So one of the things that Brooks brought up, they were compliant with everything, kind of revamping all their health policies and whatnot, but one of the things they brought up was the transportation safety, because they had already contracted with Trombley Motor Coach to have, basically what it is the transportation got changed in that now they require a staff person from the camp to be on the bus for any transportation with the campers. So that means because they hire out through, they use the big yellow school buses, because they hire out, those school buses start and do the routes, and then they drop off at Brooks, and then they pick up at Brooks for at the end of the day, and then go out to the routes, and then they go back to their destination. So he said to get a Brooks staff member on that, they have to tweak their budget, which they already had approved. They have to increase the rates for what the parents had already agreed to for what they, agreed to sign on for transportation. So because the regulations came out so late in the season, end of March, they didn't get them till April. They've already been doing everything since December, January.
Right.
They were asking for a variance for this year, and we'll incorporate it into next year's budget.
So it's just a 1 year.
It's just a 1 year.
Just kind of like a transitional variance.
Exactly. And that was more just because of the timeline of everything and how it played out. And they actually looked into, I think, NRT, they talked about getting like a representative from, like an extra body, I guess, from the motor company. And just with budgeting and everything, they said, it wouldn't be an option for this year. And so that's why they were looking for the variance.
Do either you or Brian have any objection to granting this variance? Move approval.
No.
Okay.
They've been compliant with everything, honestly.
Yeah, I read, thank you for sending the link out. I read it, and it's really, I agree.
Yeah, it just came up so late in the game where they already had their contracts with the buses. They had their staff salary set. To change everything at this point in the game was really, really going to be hard for them. The state said, give them variance.
Okay. Frank, are you making a motion?
I did.
Okay, do I hear a second?
Second.
All those in favor say aye.
Aye.
Aye. Variance passed, unanimous. Okay.
You didn't ask for the no votes.
unanimous. Okay, and then the short discussion on department reports.
They're in your packets.
Okay.
We had an extremely busy month, that time of year, so.
Any big areas
Camps.
that come up? Camps?
No. Camps, ticks, mosquitoes, septic, food, I mean, everything is full-blown at this point, so we are doing our best to keep up and get everything done.
Pools?
Pools, yep, thank you.
In the past, we've had, every year, it seemed like there was something with pools. No pool problems?
No pool problems this year.
It is only May.
Right, that tend to be more in June and July.
There will be soon, I'm anticipating, but as of right now, we've opened up several pools. I know we have a couple minor things with some permitting right now with pools, but they will be getting those done and taken care of, hopefully.
Okay. Would you like to comment, Caroline, on what's going to happen on May 30th?
Oh, sure.
There's a presentation that you're going to be involved in?
So, since we've been doing this series with the library about getting speakers every other month, we had the nutritionist, we had someone from mental health first aid come and talk. We have a pediatrician from North Andover Pediatrics and a nurse practitioner coming to talk about tick safety and prevention and what to do if you find a tick, because it's something that they kind of get flooded with phone calls, and I know it's always a hot topic this time of year and where they're already like especially bad. So we thought it would be a good opportunity for them to come out and talk to people. So that's next Wednesday, May 30th at 6 p.m. at the library.
Excellent, excellent.
Oh, and we did the running program too, with the youth department. We've had 2 successful days so far and 1 rain cancellation. You wanna talk about that?
Yeah, so we had started the health, like a health running series that we started looking into in the fall. That started this past spring. We had to, we've been working with the youth center on that, and they have agreed to kind of work with us and do a series in the spring, a series in the fall. It's a 5-week-long program. We have 75 people first time around, and it's been a great success, and everyone seems to be, you know, having a great time. There's volunteers from the youth center, or from the high school, middle school, that, you know, work well with the youth center, so it's run really smooth. So
Excellent.
yeah,
Excellent.
and we send out little information and stuff on ticks or.
So we have a mass
exercise.
email distribution list through the rec center for this program, and every week we send out information to the
with different health topics. So this week it was ticks and mosquitoes, and then I attached the flyer for the library as well.
Thank you, thank you. Tom, are you next month in,
I can, yes. That's fine.
you're going to be giving a talk?
Yeah, I can do that, yes.
Okay, thank you. Can you just tell us what the talk will be on?
I can speak about oral cancer, a little bit about risk factors and prevalence. I'll stay away from the surgery part of it.
Okay. So thank you very much. So next meeting, Dr. Tom Trowbridge is going to give a talk on oral cancer and risk factors. So I urge all of you to, at some point, either watch it live or stream it, or watch it at another time on North Andover CAM. Anyone have anything else they'd like to? Anything else?
I'd like to congratulate Joe. Let's move on.
Okay. Motion to adjourn?
Move to adjourn.
Second?
Second.
All those in favor say aye.
Aye.
It's unanimous. We're adjourned. Meeting is closed. Thank you.